One of the key things to deciding whether these cases are treatable or not, I think, is the cone beam CT mapping. It's almost a routine and almost necessary, I think, on every one of these cases where you're even thinking of treating, to get a good three-dimensional image to see, whether it wraps around interproximally, whether you have a surgical approach, whether you need to treat it non-surgically and that's your only option. And it helps you rule out artifacts. A lot of times on a PA, you'll see a radiolucency. It might be an overlying trabecular space in the bone. And it also helps you decide what type of resorption is. And what you really want to know also is how deep it goes in the root. On this one case I just showed, it was it had a very shallow depth, but we wouldn't know that unless we took a CT, and that told me that we had pretty good structural integrity of the root, especially for for all our anteriors that are barely in the bone. So that made that whole decision a lot easier. And John Muntz is asking if I polish the Geristore. No, because I think Dragoo recommended that you don't polish it. You want kind of a rough surface for the for the tissue adhesion.
Terry, can we talk a little bit more about Geristore, because
it's coming.
Yeah. Okay.
I got a whole section on that. It's coming up.
Perfect.
So I'm just going to kind of just show a little bit of CT mapping strategy here. Rob's asked me if I almost always do endo for shallow resorptions. I would say yes, just because when I go in and I'm going to prep out that defect, I want to get some mechanical retention. I don't want to have to worry whether I'm exposing the root, and I certainly don't want to do the endo later and push out material and push out my root repair material. So I tend to do it as a preventative measure, whether it needs to be absolutely done or not. You can probably get away without doing the endo in a lot of these cases, but I discuss that, and I feel it's a good preventative measure just to make sure you don't have to be a yo-yo and repeat the root resorption repair later. Certainly alternate opinions on that are very valid. Marga says she doesn't always do elective endo, and I think it really kind of depends on what you feel like, how you're going to prep that defect out if you think you're going to have an exposure to the pulp. What kind of resorption do you think this is? External, internal? Can you treat it? How do you treat it? These are the questions that we're thinking, just getting a PA radiograph and not having the cone beam imaging. In this case, the pulp was vital, had normal sulcular probing depths, and the patient was asymptomatic. This patient is a 56-year-old guy. Did I treat this one? No. The reason I didn't is that you can see from this 3D CT image that the tooth was lingually inclined. The resorption defect was on the lingual. I had a very clumsy surgical approach, and unless this patient was willing to unravel his lower anteriors and orthodontically move this tooth forward, I really didn't feel like I had a good surgical approach to even attempt this. And given the size and long geometry of that lesion, I was going to be wiping out a lot of the root, have a tough time repairing this. And in his case, we decided not to treat it, and we went right to recommended extraction and implant. One of Dr. Janian's residents, Babak, asked if we do the RCT and the repair the same visit. I tend not to. I tend to set up a visit to do the non-surgical root canal treatment and then set up a separate visit for the surgery, just because it's too long and the patients usually don't want to sit in the chair that long. But I don't think there's a reason why you have to do it that way. If anybody has any different opinions on that. Here's a very interesting case that was very perplexing to me. Looking at the gingival lesion that this patient presented with, you'd automatically guess this was pure external resorption, especially with the asymmetric presentation of the PA radiograph. This woman had slight percussion sensitivity, a cold thermal response, which is sharp and transient. And I'm going to show some video here. Now, look at that. This looks like, you can see on the left CT image that I rotated around, there's clearly an external tract there. Mm-hmm. But when I look at the transverse section of this case, I'm going to stop the let's go back here. Now I'm just going to slide this right image. I mean, this looks like a very, either that ECIR is completely wrapping around the entire pulp chamber, which it could do, or that, I was almost thinking that might be a combination ECIR and an internal resorption. I mean, can you have two different types of resorption in the same defect? But I could not find a pre-dentin layer when I treated this. So I'm going to go through these are the clinical shots of this. There's the access with the vital pulp. And when I cleared it out, removed the pulp, looked at the defect, there was no pre-dentin plate or shelf at all, and it looked very regular in its shape. And I could have sworn that's got to be internal resorption, but it has an external track. So I placed. I use a little monoject syringe with the TCA and just dab it in the site there and let it sit there. So I attempted to treat this case internally. Here's the first visit. I placed calcium hydroxide for a month, and I didn't really gouge it out. I didn't want to gouge out the cervical area that much, and thought I had great control over it. I could see the little external track at that one distal labial line angle. And after completing the root canal treatment, clearing it out, etching it, I basically bonded some Geristor from the inside and packed it into that site, thinking that might, clear up the problem. Of course, she came back 3 weeks later with the gingival lesion even worse. And this woman was extremely conscious of her aesthetics and very concerned about this. So I wasn't real excited about doing a Heather-Say resorption repair on her maxillary anterior central incisor, given her aesthetic concerns. But our hand was forced. I tried the internal approach. It didn't work. And so we went towards, so I flapped it. In this case, I did do a papilla-saving incision because it's a maxillary central incisor. I could isolate the defect, completely. And luckily, it was a very small defect, so it was pretty easy to manage surgically. Treated the gingival, the sulcus area between the bone and the tooth with some trichloroacetic acid. And in this case, and then I prepped it with a Munspur and made sure I had all clean margins. And in this case, I filled the apical half of this prep with Geristor. And then after placing the Geristor, I prepped anything that would show cosmetically supragingivally with, I placed in Filtech and shade matched it, so she'd have a nice aesthetic result. And so there's actually like a two-tone root repair in this case. There's the flapper placed, there's a suturing, and you can see on the right radiograph the two different materials. You have the Filtech supragingival and the Geristor apically. And immediately, this was about 3 weeks afterwards, the gingival lesion started to heal, and then at 6 months, it looked great. And so she had a nice, clean result. She was very happy with the aesthetics, and I breathed a sigh of relief. But this was a very perplexing case. I'd like to pose it to the experts around here. Do you think this was purely Heather-Say resorption, or do you think there was a combined internal external resorption case? I was perplexed by this one. I didn't know how to categorize this one. Any ideas?
I think it was ECIR, and I think that it's common that it'll do exactly how you described. It'll tunnel all around the canal space, and usually there's almost like eggshell thick dentin, if any, at the end. So I think it was just extensive.
I probably wiped out the pre-dentin plate in my access and probably didn't notice it. So I think you're probably right. That makes a lot of sense to me.
Yeah, you don't always have such a distinct pre-dentin. A lot of times you do, but not always. And I agree. I think it was probably just purely ECIR. See, I would have tried to probably treat this more aggressively internally than you did. At least
Dig it out with the burr more?
Yeah, more with the burr and more with the multi-step, you know, TCA, calcium hydroxide, sodium hypochlorite, and I would have tried to, like that case I showed, I would have tried to do the same thing in this area, kind of expand out. I don't know, I can't say I would have gotten a better result though, saying what, I'm amazed at how good the result that you got here. I mean, that's really a great result for an external and an aesthetic area.
Well, it is kind of interesting because it's kind of a double-edged sword. You go in, you gouge out the cervical or the root area a lot, and you know, obviously you're weakening the root. And I think there's definitely some advantage to placing a fiber post like you and Marga do in all these cases. And I tend to be a little more conservative in my management, and you know, hit it with the TCA. I don't necessarily get all the resorption in a lot of these cases, and just kind of willing to go back if I have to you know, either do an external repair if I have that surgical option, it's accessible, or go back in and dig it out some more if necessary. But it's kind of interesting how a lot of these, even though you have resorption, you may not completely eliminate the feeders. If you nail enough of the circulation, it seems like a lot of times you can get these into remission and they last a long time. But I'm going to show some of the failures that I have. So this doesn't always work. And maybe we are being, you know, maybe we're better off being aggressive and really burring these out. But I'm perplexed on that, you know, whether I should burr them out or be conservative. It's a tough decision.
Yeah, I mean, when I quote burr them out, I go until I start getting close to the outside, and then I stop with the burr, and then I just use the acid and the calcium hydroxide and the sodium hypochlorite. And it continues to expand out on its own, but it takes several appointments to do it.
Rick, do you take radiographs along the way to check?
Yeah, I always take one. I take one before I start and afterwards. So, like that case I showed, those radiographs were all on. Oh, you mean with the burr you're talking about?
Yeah.
Oh, yeah. Yes, I do. Yeah, and I know I saw you posted something the other day about how you use an apex locator.
Yes.
Yeah. I never thought of that. Why don't you describe that?
Maybe it comes up. It's the case that I sent Terry, the one with the one of the upper molar. I'm not sure whether Terry included it, but if you...
I think I have that at the end of the case series.
Okay, then I'll explain that later on.